I'm Antonio Facciorusso, the first author of the paper recently published in Gastrointestinal Endoscopy entitled Comparative Diagnostic Performance of Different Techniques for Endoscopic Ultrasound-Guided Fine Needle Biopsy of Solid Pancreatic Masses and Network Meta-Analysis. There is limited evidence on the comparative diagnostic yield of different sampling techniques during endoscopic ultrasound FNB of pancreatic masses. Therefore, we decided to perform pairwise and network meta-analysis comparing the diagnostic yield and other diagnostic features of different tissue sampling techniques for EUS FNB of pancreatic masses, namely slow pool technique, dry suction, modified wet suction, or no suction. The quality of the evidence of our findings was also assessed using grade criteria. All randomized trial testing FNB needles, mainly with 22 gauge, for tissue sampling of pancreatic masses were included. Primary outcome was sample adequacy, with rate of blood contamination and tissue integrity rate as secondary outcomes. 9 randomized trials, 756 patients were included. ROSE was available only in one study. 6 trials used end-cutting FNB needles. When combining direct and indirect evidence through network meta-analysis, no suction technique resulted significantly inferior to the other techniques in terms of sample adequacy. On the other hand, none of the other direct and indirect comparisons showed significant differences among techniques. Consequently, modified wet suction was the best technique, Sucra score 0.90, followed by dry suction and slow pool, with no suction showing the poorest performance in terms of sample adequacy, Sucra score 0.14. Dry suction had higher rates of blood contamination compared to slow pool, risk ratio 1.44, whereas no suction led to less blood contamination compared to the other techniques. As a consequence, no suction significantly outperformed other techniques and ranked as the best strategy, Sucra score 0.99. On the other hand, modified wet suction, Sucra score 0.32, and dry suction, Sucra score 0.12, showed poor performances in terms of blood contamination of the sample. Modified wet suction significantly outperformed dry suction in terms of tissue integrity of the sample, risk ratio 1.36, whereas none of the other direct and indirect comparisons were significant. Therefore, modified wet suction ranked as the best strategy, Sucra score 0.89 for tissue integrity rate. Results of the main analysis were confirmed both in randomized controlled trials using end-cutting FNB and in those using the old reverse bevel needles. The overall body of evidence was rated down for serious risk of bias since the included trials were unblinded and at high risk of performance bias and for imprecision due to the wide confidence intervals crossing unity or failure to reach the optimal information size. Therefore, the overall body of evidence was rated as low quality. Our findings suggest that modified wet suction seemed to determine high rates of samples with blood contamination. However, the significance of blood contamination for assessing histological samples could be questioned. In fact, as those samples collected with a modified wet suction were most frequently highly blood contaminated, its diagnostic performance was not impaired, and its tissue integrity significantly outperformed other techniques. Finally, based on our results, the two best techniques seem to be slow pool and modified wet suction, and the choice between the two depends upon agreement and preference of the pathologist, considering the lower rate of blood contamination using the slow pool technique. In conclusion, based on this systematic review with network meta-analysis of different tissue sampling FNB techniques for pancreatic masses, modified wet suction seems to provide high rates of samples integrity and adequacy. While the rate of blood contamination is significantly higher with modified wet suction as compared to slow pool, this aspect does not seem to impair the diagnostic performance of this technique.